Hi PTA 105 students, this is Loretta again. I am going to talk to you a little bit about reflex and sensory testing. We will start a little bit of reflex testing in the next lab, in the second lab, and then we will do some skill checks on reflex and sensory testing in the last lab. Those will be our last skill checks. So with reflex and sensory testing, there certainly aren't as many measurements to do as with goniometry and manual muscle testing. There'll just be a few, but again, it'll be just an informal skills check where you'll be asked to choose a couple of sensory and reflex tests that you will perform. So in the lab, we're going to do an introduction to deep tendon reflex testing with a reflex hammer, just some key ones, and general sensory testing, doing sensory screening and a sensory exam. There are videos in the modules that I want you to watch before lab, and that'll be before the third lab, just about sensory exams and deep tendon reflex testing. So we do the sensation testing to examine sensory integrity, and we're determining the patient's ability to interpret and discriminate among incoming sensory information. So you can have sensory impairment at any point in the sensory system, from the peripheral receptor or peripheral nerve, the nerve root, the spinal cord, or the brain. So you might have completely intact receptors, peripheral nerves, spinal cord, and everything, but you might have had a problem in the brain that causes some sensory impairment, or it could be just the opposite. Your brain and spinal cord and nerve root and everything are perfect, but there's something wrong with the receptor at the other end, or there could be something wrong anywhere along that chain. So it's kind of an interesting stuff, and we will definitely go way more into it in neuro next winter, and we'll talk about the spinal tracts that the sensory information runs in and all sorts of other wonderful stuff. But for this class, you won't need to know any of that, or right away. So usually sensory testing is part of the initial PT evaluation, but as a PTA, you might also need to assess sensation in a patient. So you might have someone that has a new prosthetic or orthotic device, and you have to test to make sure that they are monitoring their skin integrity and their sensation, because you want to prevent skin breakdown. So a lot of times the PTA is retesting after, obviously after the initial eval. The PTA can collect data and perform the tests and report the results of the test, but it really is up to the PT to interpret the tests. So as PTAs, we are not interpreting the tests, we're just collecting data. So that's kind of a good distinction to think about. A lot of times in the initial eval, the PT is going to be doing comprehensive sensory testing, whereas the PTA in later visits is maybe only going to be retesting one or two things. So once the PT has tested reflexes, we don't need to do it every time. So we will just be retesting some key things just to demonstrate whether they're improving or worsening. Excuse me. And maybe we're retesting just a few key things. So there are lots of different causes of sensory impairment, just like I was saying that the sensory impairment could come anywhere in the path. You can have a million things that can cause it. You can have peripheral nerve disease or injury, nerve root compression from a disc injury or stenosis, something in the spinal cord. You can have a spinal cord injury. Burns can cause altered sensation. A CVA or any kind of hemiplegia, you're going to have different sensation, different sides of the body. Multiple sclerosis often has some sensory impairments, traumatic brain injury. Normal aging also alters sensory function. So as we age, we are going to have a decreased response to tactile sensations. We're going to have visual and hearing losses. It's something, so sensory impairment comes up fairly often in a PT setting. There are lots of different patterns of sensory loss as well. We're going to talk a little bit in this lab about dermatomes, and we will talk a lot more about that in neuro as well. Nerve root injuries tend to demonstrate sensory loss in the corresponding dermatome. So we'll talk a little bit about dermatomes on the next slide. But you could also have peripheral nerve injuries that show loss in a peripheral nerve distribution, and I have a chart that you guys can download that shows the differences between the two. With central nervous system lesions, you can have crazy distribution of sensory loss, and so again, as PTAs, it's really not up to us to interpret whether or not we have a peripheral or nerve root injury, but it's just another one of the clues that we're going to collect data on and provide to our PT, who's then going to interpret the data. So as far as sensation goes, there are different categories of sensation that we're going to be testing, and it's based on the type or location of the receptor that's responding to particular stimulus. So the three different times are superficial, deep, and cortical or combined sensations. So superficial sensations are detected by receptors that are located in the skin and subcutaneous tissue. Pain, temperature, light, touch, and pressure. And again, we'll go over those in much more detail in neuro. But probably if I just ask you to come up with something where you're going to test those things, test light, touch, I'm sure you could make something up that would be a pretty good test of those things. With deep sensation, we're going into other receptors, ones that are located in the muscles, tendons, joints, ligaments, and fascia. So it might be a Golgi tendon organ or muscle spindles, something that's going to respond to a different type of stimulus. So our deep receptors, they're located in those deep tissues, and they're responsible for position sense, which we call proprioception, movement sense, kinesthesia, and vibration. So a lot of times people will have losses in superficial sensation after an injury or a surgery particularly, but they still maintain those deep sensations. So it's kind of interesting to compare the two when you're doing the testing. So the combined or cortical sensations, there's information from those external receptors and proprioceptors, as well as the cortical information in the sensory association area of the brain. So we get the information in from the periphery, and then in the cerebral cortex, we have to say, wow, what is that? Is it hot? Is it a light touch? Is it a pinprick? So we have areas in our brain that can associate those with identifying what the stimulus is. So it's a much more complex than the superficial sensations. So as far as guidelines for sensory testing, you have to have a patient who has cognitive status that allows them to actually participate. They have to be alert and oriented to time, place, and person. They have to be able to understand your instructions, and they have to be able to communicate with you adequately so you know what their response is. You have to instruct them to be accurate and not guess on their responses. I know probably a lot of us have been to the eye doctor, for example, where they tell you, they show you two different adjustments for your vision, and they ask which one's clearer. Sometimes you're not really sure, and you could guess and say, oh, maybe it's the first one. But with the sensory testing, you really want them to try to be accurate. And if they don't feel anything, just to tell you that they don't feel anything. So it's in our role as the examiner, we have to educate the patient and tell them why we're doing it, what the goals are, and how important their cooperation is. So you have to make sure they're comfortable and relaxed, and preferably in a quiet room with no distractions. If you're in the middle of a busy gym, it's a lot different trying to distinguish between sensations than if you're in a quiet room where you're not distracted. So you might do it on an area that you know is intact and say, okay, this is what it's going to feel like, the 2-point discrimination or something like that, and now we're going to do it over on this area. So we have to kind of teach them how to respond to these tests. You want to block their vision, so you can use a blindfold or a folded towel, or you could just have people close their eyes as long as you're sure they're not peeking. Because people really want to do well on testing. They want to impress us at how well they did, but we want to get some accurate testing, and so we want to make sure we block their vision. When we're testing sensory, we want to begin distally and work proximally, because sometimes, although not necessarily, deficits might be more obvious distally. So we're going to test areas in each dermatome to find deficits. So we'll talk a little bit later about where the most distal place for each dermatome that we are going to test in the lab is. If we do find some sensory deficit, we want to try to locate the boundaries of the sensory impairment. So, oh, well, you can feel this here, but you can't feel it over here. So just to kind of help the PT determine the location of the lesion, or whether things have changed or not. So a lot of times as PTAs, we're not doing the initial test. We're doing tests later on, and we're saying, do they have more sensation now than they did when they were initially tested? So different facilities, of course, use different evaluation forms, and sometimes they don't use one at all. They just have, you're just writing things down verbally. And so that is something that wherever you work, you'll be trained in that different things. So we're not going to use a specific form, but just know that there are lots of different forms out there. So getting to dermatomes. So a dermatome is the cutaneous area of the body that's innervated by a single spinal nerve root. So there's some overlap at adjacent dermatomes, so that's why we want to test at the most distal aspect of the dermatome, because they have the least amount of overlap. So peripheral nerves have a much more clearly defined border, and CNS lesions tend to be more widespread. They're kind of all over the place. So you will find differing sources for dermatomes. If you look at a dermatome chart in this book versus this book, they might be a little bit different. So I would like, for our purposes, to use the form that I have in the download section of the module, just so we're all working off the same deal. With the trunk dermatomes, we are not going to be necessarily concerned with those. We are more working on the extremities. So just so you know that, now would be a good time to download that form. Okay, so here is a list of the most distal areas of each dermatome that I want you to know. So you can see it's not all of them. It's just some of them. And so we're going to just see, is a nerve root involved? And I'm not going to read through all of these. I know you guys can all read. And so we will go through these in the lab again, though, and just knowing where the most distal aspect of each dermatome is. So if you test at, like say we're going to test C6 dermatome, and you test at the thumb, but if we're going to test C7, we test at the middle finger. So I think that's pretty straightforward. So the grading of the sensory testing and the reflex testing is different. Just like everything, it has its own grading scale. So there's not a number scale with sensory testing. There's a word scale. So intact, it's just what it sounds. It's a normal, accurate response. And so that's how you will report it. You will say sensation, light touch sensation is intact at whichever dermatome you're testing. A decreased response is there is a response, but maybe it's delayed. Exaggerated, hypersensitive, increased sensitivity, or even after the stimulus has ceased, a lot of times you'll get more. They'll still have sensation associated with it. Inaccurate, meaning they just have an inappropriate perception of it. you're doing maybe a sharp point and it feels like a dull point to them, or some other inaccurate perception. Absent is no response. They can't feel it at all. You say, am I touching you now? And they say no, even though maybe you are. So absent. Inconsistent or ambiguous. So sometimes you'll get people who you test them in one area and they can't feel anything, and you go back there and they can feel it. So obviously that's not, but you report that their sensory testing was inconsistent. You're not really getting any good data out of that, but you still report it that way. So on to reflex testing, straight out of sensory testing. So reflexes, they're involuntary, they're predictable, and they're a specific response to a stimulus. We are specifically going to be testing only 4 deep tendon reflexes. And they indicate the state of the peripheral nerve or the nerve root supplying that reflex. So when we look at the 4 down here that we're going to be testing, the biceps tendon, it's the nerve roots C5 and 6, the triceps tendon C7 and 8, the patellar tendon L3 and 4, and the Achilles tendon S1 and 2. So a lot of times a PT will very quickly in an evaluation, I hope that some of you, if you haven't already, during your clinical assignments, will get an opportunity to watch some evaluations. But the deep tendon reflex testing is usually quite quick. They just go through, tap the different reflexes, and what we're looking for is differences between the sides. So there's a little picture of a reflex arc here. It's you hit the tendon with a reflex hammer. It delivers a quick stretch to the muscle spindles, which are embedded in the muscle fibers, stimulates the spindles, which cause the impulses to go up to the spinal cord. The sensory neuron synapses with the motor neuron, and the impulse goes back to the motor nerve, causing the muscle to contract. So I think everybody has had this done to them, where your patellar tendon's been tested, or one of the other tendons has been tested, and you just get that little knee jerk. So when you're examining the reflexes, the patient should be relaxed, and we'll do this in lab. You're going to test with the muscle that the tendon's going to be tapped. So for example, say that you're doing the patellar tendon, you want those quadriceps muscles to be in mid-range and relaxed, so the tendon's on slight stretch, so your knee's not fully extended, nor is it fully flexed. You're in mid-range, the patient's relaxed, and the muscle's relaxed. So what you're looking for is the expected joint movement. So when you hit the patellar tendon, you're expecting knee extension, because you're going to get that little muscle contraction in the quads. If you don't get any joint movement, you might just palpate the quadriceps and feel a little bit of muscle contraction. So there's this little thing that was discovered in the 1800s by a Hungarian physician, and it's named after him. It's called the Jendrassik Maneuver. And sometimes if you can't get a reflex, you can have them perform this maneuver, and we'll describe it on the next slide. And it's almost a distraction technique to keep them from tensing up, basically. So kind of fun little experiment to do. So really, to be of clinical significance, you want to have asymmetry between the sides. So there's no reason to be overly concerned if the reflexes are absent or diminished or exaggerated bilaterally. So if you have exaggerated reflexes on both legs, well, you have exaggerated reflexes on both legs. But what you're looking for is a difference between the sides. So if you're, a lot of times with hyporeflexia, diminished or areflexia, it's caused by a peripheral nerve or nerve root lesion, like an impingement or entrapment or an injury. hyperreflexia or exaggerated reflex are a lot of times caused by lesions of the central nervous system. And we will talk about that a lot more in neuro as well, as how do you distinguish between a CNS and a PNS lesion. But we're just kind of concerned in this lab is how do you do this thing? How do you do the deep tendon reflex testing? So the Jendrassik Maneuver, you clench your teeth, you hook your fingers together, and you pull on them. And then you hit the knee, the patellar tendon right below the knee with the reflex hammer, and you're trying to get the patellar reflex. So a lot of times you get more of a reaction, probably because the person's not tensing up their knee. They're worried about tensing up their arms. There's some other ones that you can do. It's kind of, I don't know, it's like one of those things, like a bar trick that you use to get someone to buy you a drink or something. But it does actually work. So we'll try it in lab. It'll be fun. But you can also use it to distract patients when you're doing other procedures if you're really trying to. There's something that you have to get the patient to relax. You have to distract them in some way. So it's kind of fun, a little gimmicky thing, but it does actually work. So of course, reflex grading is different from sensory grading, different from manual muscle test grading. They have to have a different scale for everything. So 0 is no response, 1+ is a diminished response, 2+ is your average normal response, 3+ is exaggerated response, and 4+ is hyperactive with clonus, which we'll talk about in lab as well. No idea why there's a plus on all the numbers. That's just the way it is. Some of these scales will drive you crazy, but just know that 2+ is average, less than 2+ is diminished, and more than 2+ is hyperactive. So it's just a funny little scale. And there are a million other ones too. Yay. So we'll go through that, the grading of the responses in lab as well. And a lot of it's, fairly subjective, but you'll figure out how to do it. So that's really just it. The kind of the basic introductory material for sensory and reflex testing. And we will go more through that in the lab. And in the next lab, we'll just start probably at the end of lab, going through deep tendon reflexes, and then we will go more into the sensory testing in the third lab, where we'll also do posture assessment. It's just another little addition to your bag of tricks. And hopefully you all will enjoy the testing, because it is kind of fun and interesting.